My name is Marion Subklewe, and I had the T-cell bispecifics and CAR T-cell program at the LMU. And I'm happy to give you a short summary on the pro and con session from the third CAR T-cell meeting of EVIA and EBMT. And I had the position of pro T-cell bispecifics, and my counterpart was Catherine Thiblemont, who gave a pro CAR T talk, and we focused on the setting of B-cell malignancies. So clearly, first of all, there's no randomized trial in any entity comparing bispecifics to CAR T cells. So the answer pro-BiTE or pro-CAR T cells cannot be answered in any disease entity. So we can talk about parameters, and I like to highlight some that differ in principle, like construct, design, manufacturing, and production time. And there's also data from clinical trials giving us hints on aspects like safety and efficacy. So first, I'd like to remind everybody that bispecifics rely on co-stimulation through the target cells, or it might be the clustering of multiple CD3 molecules in the immunological synapse, whereas the CAR T cells provide their own co-stimulatory molecules. However, although this appears to be a clear weakness for T-cell activation in the bispecific setting, there's also a lot of data that T-cell fitness prior to leukapheresis and T-cell subset composition and possible manipulation during manufacturing impacts efficacy. And clearly we see T-cell exhaustion after CAR T-cell transfusion. So I think the data supports the notion that T-cell fitness is highly relevant in the BiTE setting or the bispecific setting anyway, but also in the CAR T-cell setting. If we look at manufacturing and production, bispecifics are an off-the-shelf product for immediate use and provide a stable, reliable product, whereas CAR T cells are faced with the challenge of production failure in about 10% of the cases, and out of spec products in about 10% of the cases. And in some trials, there are conflicting data, but in the ZUMA-9 trial, this was associated with a lower response rate in CAR T cell expansion. So the downside of CAR T cells, we have the vein-to-vein time, we have manufacturing challenges leading to production failure and out-of-spec products of unknown significance. And if we look at safety, comparing T-cell bispecifics and CAR T cells, we observe a lower rate of CRS and ICANS using bispecifics, and particularly with novel constructs given subcutaneous. And importantly, we do observe, besides the higher incidence of CRS and ICANS, also long-term cytopenias and immunosuppression after CAR T cells in a significant proportion of patients, with prolonged neutropenia in some cases, as also reported by our group, also at this EBMT meeting. And we see also long-term lymphopenia, hypogammaglobulinemia, and an increased rate of opportunistic infections. So this has to be taken into account in the CAR T cells setting. And last, looking at efficacy, we clearly, as I said, have no comparative data. And in particularly, if one considers intent to treat analysis with the loss of patients, as I said, during the CAR T cell pipeline and production, it is completely open if the data that is provided from the non-randomized trials are comparable. Also, if you think of the different patient cohorts treated, and clearly also depending on the different disease entities. However, so far the data that is provided implies that there's a higher response rate after CAR T cells, particularly in the setting of relapse refractory ALL. But these were much younger patients with an average age of 11 compared to the Blinn data from the Tower trial with an average age of 43 years old. And we also have reports on higher response rates in the aggressive diffuse large cell B-cell lymphomas, but also in follicular lymphoma using CAR T cells versus bispecifics. But clearly, as I said, different patients, different trial design, different readout, often not intent to treat. And I think we clearly can conclude that the comparison is difficult due to the different scenarios and the rule not to compare different trials with different patients and design. But I think we will eventually need a comparison, and we need to define biomarkers to decide which immunotherapy is safe and most successful for each individual patient, and clearly which platform is most suitable in an individual personal approach. And I think what we conclude from all these trials, and there's an increasing awareness that T-cell subset composition, T-cell fitness is a very important component for the success of T-cell bispecifics as well as CAR T-cells. So I will have to wait more data to conclude on this. And clearly at the moment, it's amazing that we have two platforms that are evolving as new treatment options for our patients.